Thanks a lot, Sherry. First of all, I want to thank you for the honor of being here. I've got a heavy Spanish accent, so if at some point I'm not fully easy to understand, please do not hesitate to let me know, and I'll try to make myself more understandable. Okay. So thanks. Well, what I aim to do today is is not teaching anything. So basically, I want to share our experience in Spain working in male breast cancer research, basically. So I do understand that I am in front of a quite wise audience in terms of knowing the disease and the circumstances of the research in this disease. So I'll very much like the interactions with you so we can learn together, because one of the probably, and I will be highlighting that later on, because but one of the things that we've learned a lot during this research program in male breast cancer is that, in particular in these areas of rare diseases, if you want to call it like that, or not, or infrequent diseases, is where you need most the interaction, and you need most the interaction in particular with patients, because there is a clear energy coming from patients having infrequent disease. And we've learned that, this is a must for any successful research program, interaction with patients. So I'm very happy to share this with you. So what I will be sharing today, as said, is our experience in HEICAM. HEICAM is the Spanish Breast Cancer Research Group. Okay, it's a cooperative group, non-profit cooperative group, where fully focused on breast cancer, obviously mostly on female breast cancer, but we started a male breast cancer program some years ago. And what I like first to discuss with you is why we did that. Because probably, and in that you will be expert, the first time you face the need to do some research in male breast cancer is because we as clinicians face that we have male breast cancer patients, and there is no any specific evidence on that. And you start when you are young, you start assuming that, well, I mean, all the evidence comes from female, but at some point you start understanding that male breast cancer is a different entity, and that is the initiation of the spark that starts this program, as would probably have been the case in most research programs in this, when you start to understand that male breast cancer is a different entity. And the claim initially is to kind of demonstrate that male breast cancer is different from that. I tend to say that is no longer a need nowadays, because I mean, if you want to compare male breast cancer with female breast cancer, you will start saying with which female breast cancer, because female breast cancer is no longer a disease at all. We know there is a cluster of diseases, and as much as we know, we tend towards individual classification. Obviously, we are not there. We are in subgrouping so far, even in female breast cancer. But obviously, I mean, there is no need to claim that male breast cancer is different from female breast cancer, because not even female breast cancer is similar to female breast cancer, if you see what I mean. So there is no longer that need. So the second phase of somebody entering this arena of male breast cancer research is saying, well, I mean, the biology of male breast cancer is distinct quite clearly. So in studying male breast cancer, we are going to learn a lot in general on breast cancer. So it's not that point of confrontation of male versus female and trying to claim for this individuality of the disease. It's not that. It's simply that this is another subgroup of breast cancer, and we need to learn because it's quite distinct. The biological features of it are quite distinct, and so there is an opportunity here to learn a lot in general of breast cancer. So what I say to my colleagues frequently is that it's like, in studying male breast cancer, we're going to learn a lot, even for female breast cancer patients. So this is a process we've been going through. So when we did that in HEICAM, in our cooperative group, there was a couple of investigators. One was a colleague in Madrid and myself, that we decided to boost our registry on male breast cancer in Spain, okay? And that is what I will be showing you first, the first results of this registry that we have put together with up to almost 800 male breast cancer patients together during the last years. And that I will be showing, and then I will explain you at what point we are and what is our current strategy, or what we are trying to do from an basically international research perspective, and then we'll finish with some lessons learned. So this is the point. So basically, as said, the Spanish Male Breast Cancer Registry has put together data, clinical data, and samples for almost 800. Literally, I think it's 778 male breast cancer patients in Spain during the last 6 years. Okay, so this we have show our first results in 3 conferences through posters. We're in the process of publishing it, but so far we have shared that with the rest of the scientific community through posters in 3 major conferences. The first one was that poster in ASCO this year. Well, it's not the first one, but one of the ones in which we disclose our research in findings in earlier stage. Believe me, I'm not going to go through all these tables because that would probably bore you to death. But it's always good to know that what we found closely resembles in terms of describing the series. It closely resembles what the rest of series of male breast cancer patients have shown. So basically, as said, we put together almost 800. Obviously, we don't have all data from all patients. So altogether, they are 78, but we don't have all data from all patients, as I said. So basically, our median age of our patients is around the 60s. Most of them are white, corresponding to our social scenario in Spain, okay? And then, well, there's some data on previous tumors and a history of familial breast cancer. One of the well, and I will be focusing on that, is that one of the first findings we got is that only a minority of our patients were being tested in their family risk. And that was one of the things that thrilled us most initially, because, I mean, we're saying, well, in doing this series, the first outcome is that we're going to audit the practice on breast cancer care in this patient in Spain. And the first outcome showed us that there's a clear room for improvement in care for these patients. One of the things that nowadays is well accepted is that most of these patients should be tested in a familial rated risk, but they won't. And so there is a clear benefit in doing this from an audit perspective, because you know that as these patients are treated in a scattered manner in different centers, I mean, not concentrating them in reference centers produces this kind of as said, room for improvement in their care. There are certain things that are not done that should be done. Well, nevertheless, as you know, most of these patients are going through a mastectomy, and that this one of the other paradigmas that we want to challenge with series. Why should all patients, most patients by default, undergo a mastectomy? While we perfectly know that conservative surgery is a good option. I mean, and particularly radiotherapy for male breast cancer probably is even less toxic than it is for most female patients. So why is not this offered to our patients? So as said, from an audit perspective, I mean, it is a fantastic exercise in Spain. And then we get we were discussing previously with Professor Leone, with Dr. Leone, one of the markers that is commonly used in breast cancer, which is Ki67, that you probably know that has a clear prognostic value in female breast cancer. It's been challenged in previous series, the value of Ki67 in males, and in our series as well. I mean, Ki67 does not have the prognostic value that it seems to have in females. So there's a number, again, of distinct biological features that we are finding out in our series. Another area as a result of our series is the result on regarding germline testing, as said. And out of the 78 patients, only 186 were tested for germline mutations. I mean, BRCA1 and 2 at least. So that was a call for attention. So heads up, not all patients are being tested for genetic risk. So that is the only thing that we have disclosed. And I think that with this change in our paradigm of care in Spain, of those 24% of patients that were tested, almost 20% of them, had a known pathogenic mutation in BRCA1 or 2. This is well known. This is nothing new. But at least the thing that we have a double check is that we should be doing that. And there is a description here. And I mean, I can make these posters, hand them to you because they've got because they've been published in these conferences, and there's something that we can hand to you easily. Okay, and so you can go through these tables. There is a description here of the difference between BRCA mutated and non-mutated patients, but I don't want to focus on that right now because it's not. One of the other things that we're doing is that checking that BRCA mutated patients had a worse prognosis. And that, again, is called for attention, in particular when BRCA mutated patients have nowadays specifically drugs address for these mutations or for the biology of this disease. So again, this put us in a situation in which we need to reconsider whether or not these PARP inhibitors, which are the drugs approved for women with BRCA1 breast cancer, can be used and are used in males as well. As discussed previously with Dr. Leone, one of the challenges that we are facing is the approval process for male breast cancers here. So one of the other biological features that we found, and this is comparing the intrinsic subtype change. Do you know that intrinsic subtype, that namely are nowadays luminal A, luminal B, HER2, basal, and normal subtypes? That probably rings a bell. This is frequently used in female breast cancer. This is a classification through molecular features beyond other more anatomic features, molecular features. And one of the well-known events in the process of patients through early and advanced disease, here you go. What happens with, this is an example of with female in terms of change of subtype during the natural process of female breast cancer. Here you go, primary tumors. Sorry for the Spanish, I didn't have this in English. Primary tumors, axillary lymph nodes, and metastases. Okay, so you can see that the luminal A percentage of patients decreases throughout the evolution towards more advanced disease. The luminal B increases, and the HER2 and basal subtypes increase too, and this is in female. Nevertheless, that's not the case in male. And this the graph downside here is from our series. Males are luminal mostly in the early disease and luminal mostly in the advanced disease. So this change in subtypes, namely this classification of subtypes, probably is not as useful as it is in females for males. So again, we need specific classifications for this change in the biological characteristics through the process of disease from early disease to advanced disease for males. So these are some of the findings that we had in our series. Again, this is another example or a specific outcome, which is the outcome of patients with advanced disease metastatic disease, okay, being treated in first line, depending on whether or not they were treated with hormonal therapy or chemotherapy. And as you see, most patients being treated with chemotherapy had a worse prognosis. Well, obviously there is a bias here, which probably those that are being treated with chemotherapy in the first instance is because they have a more advanced disease or a more aggressive disease. So this is not particularly robust as a finding, but again, it's heads up on why this process of chemotherapy might not be as useful as it is in certain female breast cancer for male breast cancer. But that is only a very, very preliminary finding, okay? I don't want to focus on that. And this is the disease outcome depending on whether or not they are HER2 positive or HER2 negative. And there was a question there by Greg before regarding Professor Leone's presentation. I mean, I'll be honest with you, Greg. Probably the question on why HER2 positive male breast cancer are not included in trials is because they are the rarity within the rarity. So, I mean, it would, and as we know that HER2 mandates a full, complete different biology in breast cancer in general. I mean, they cannot be put together with HER2 positive with HER2 negative easily in trials. So, I mean, it's a very relevant question, and probably these patients need even a more specific approach. Male breast cancers with HER2 positive disease, and we all have male breast cancer with HER2 positive disease in our clinics, but they are rare among rare. So that's probably a question. So I'm finished here with our initial findings in our series. So basically what we are doing currently is some translational research with all these series. We will be publishing the clinical findings of the series, but our most relevant interest is to produce some translational research programs on the basis of all these samples that we have. So we have already done a proteomic profile research. We will get a grant from Gilead, and we are starting that an immuno-oncology program with these samples. And I tell you something, in immuno-oncology, you know that immunity has become the major hope in cancer in general. Breast cancer so far is not the most the most active area for immunotherapies, you know, and this is one of the challenges we are facing in breast cancer in general, how to elaborate or produce a more effective immune approach for breast cancer patients, and that applies both to female and to male. But there's one particularity within males, that is the host. The host is quite different between males and females. This is beyond any doubt. And we think that immunity in males and females is going to be different. So what we have here is a fantastic opportunity to have a different host tumor relation in terms of the immunity of the host against the tumor. In terms of the immunity of males and the immunity of females is going to be different, and we already know that males and females are different in their immunity. So probably in a starting male breast cancer immunity, we are going to learn a lot that will be probably going to be very useful for female also. So this is the point I was coming at the very beginning. In studying male breast cancer, we're going to learn a lot in general for females too. So that is a great point. Whereas searching for funding for additional translational programs with our series too. And this is the third part of my talk here. What we've started now is within our HICAM group, we decided that I mean, doing this at a national level, well, might have its impact, but obviously makes no sense in terms of not putting our series at the disposal of the international scientific community to validate previous findings. So what we did, we've called our translational research Ardern. Ardern is the name of a French surgeon of the 14th century that allegedly is the first one describing a male breast cancer. So I haven't dig very much into history, but he was a military surgeon that it seems that he described for the first time a male breast cancer. So we've called with his name our translational consortium, okay? And we call it the Arderne program. And what we have started to do is, well, you know, we've got 800 patients, but there is an international male breast cancer program that you know that Professor Cardoso has shown you, has led. And so we call her, basically we call her while we were finishing our series saying, look, Fatima, we need to put together our series and we need to validate with your previous finding in our series. So what would be the most prevalent, the most interesting questions to be addressed that you could use our samples for? We could all together. And what we did, so we first clustered together a unique repository of samples, because we do not think there's going to be a lot of series that these ones in a near future, okay? So we've got a unique repository of samples in order to validate practice changing hypothesis, because so far we haven't changed the care for males, okay? So first we need to define those hypotheses that have been so far in a preliminary fashion been described through literature so far. So we want to take profit of the international consortium to accelerate findings on key biomarkers, and once for a for change clinical practice. So we want to use our service to change clinical practice for males. Okay. So we did that. We went through the most relevant findings in translational research in male breast cancer, and believe me, I'm not going to go through that. You know, there is in the specific molecular subtyping of male breast cancer, which namely M2 and M1. There's something that some North European groups described some years ago and had been validated in terms of the prognostic value of these two subgroups. Luminal M1 and luminal M2. Allegedly, luminal M1 accomplished for 2/3 of cancers. They are ER positive, as almost all, but they are more aggressive, have more DNA alterations, and have a worse prognosis, while the M2 is a less aggressive subtype. So this has been published a number of times, but nobody uses them. Nobody uses this classification. And there is not a specific prognostic signature for male breast cancer with early breast cancer. And we thought that our series could be a fantastic opportunity to validate some of these findings and to change practice. So we took this. Another thing that we took is specifically molecular subtyping or male breast cancer. I'm not going to go through this because, but just to highlight that this is being produced. This molecular subtyping on male breast cancer is produced by John Martin's group. It's been published, communicated in several congresses, and what they've been doing, and they keep doing an extensive work in this RNA-based subclassification of molecular subtypes of male breast cancer. So basically, we thought, well, we need to call these people, this group on board, and you will show there's something that we've done, okay? The other group that was doing very interesting research was the John Bartlett's group. And in particular, they were doing some, this is one of the most relevant papers that they have produced, testing the already useful signatures, prognostic signatures of early female breast cancer in male series. And what they have found is that they are all prognostic, but they do not overlap very well. So there is a clear room for improvement in prognostic signatures for early male breast cancer again, okay? So this is John Bartlett's group. And this is additional findings from them in terms of the genetic aberrations in these different subgroups. And again, this is aberrations that may bear prognostic value in early breast cancer. I don't want to go through that. And the other area in that we were interested, as I showed you before, immunity in male breast cancer, we were interested, but we know that there were other groups, in particular the groups of Professor Laura Ottini in Italy. They were doing some nice work in these immuno clusters in male breast cancer. So again, we thought that we needed to put together their ability to produce these nice results with us. And in doing that, well, basically we start calling people, and we have put together a consortium. And actually, I'm very happy that Valerie is around, because she knows that we've been a couple of times together. And last time it was last week, to be honest with you. And so we've put around the same Zoom video conference these guys. So basically, Fatima, representing this EORTC Male Breast Cancer International Consortium. These guys in the top right hand are my colleagues in HICAM. Okay, they are translational researchers and clinical researchers. Maria Caffarelli is an expert in immunity. Noelia Martinez is the other principal investigator of the clinical series. Federico Rojo is a pathologist with an expertise in male breast cancer. And Javier Pascual is another translational oncologist. Okay, and we've put them together with those groups that, at least in Europe, has produced nice results on the areas that have just mentioned. Valerie, you know her well, and there's no need for further introduction of her. Laura Tinia said, Karen Taylor is currently running John Bartlett's laboratory in Edinburgh. So John Bartlett has retired, or is in the process of retiring, and Karen Taylor has taken over his work on that, and John Martens, as already mentioned. So we've put all together there. I will say, well, listen, guys, we've got a new series, series of 800 samples. Why don't we validate some previous findings in order to produce some practice changing evidence? Okay, and that's where what we are in the process of doing. Last week we had a meeting, and we have decided to write a draft, well, no, to write a program, to write a grant application project, okay, in order to keep applying for grants in the international arena, in order to approach the following areas. First, we want to clarify whether or not the M2, M1 subtypes defined by RNA sequencing are the most accurate way of establishing prognosis in the early adjuvant setting, and if they are not, which is the platform? So we need to validate that, whether or not there is a specific platform for males, and in order to decide on adjuvant chemotherapy, and in order to decide in the adjuvant use of CDK inhibitors, as already mentioned, okay, in particular for chemotherapy. So we need to know whether we can use recurrence scores or MammaPrint or these M1, M2 subtypes as the best way of clarification for patients. That is the main hypothesis that we want to validate in our series, okay? And this is how we are going to do. I mean, the evidence has already been produced in the EORTC series, over 1,800 patients. Okay, so we've got this additional 773 patients available with around 700 paraffin embedded blocks, and we will be doing that. Okay. And there are two big therapeutic hypotheses that we want to evolve. Beyond this main hypothesis, we want to study on the androgen receptor as a disease-specific relevant target, because there are, as mentioned, I mean, androgen receptor is almost ubiquitous in male breast cancer. More than 90% of male breast cancers overexpress the androgen receptor, and it has not been adequately studied as a therapeutic target, and there are new agents in this arena that appearing in the therapeutic research, clinical research for the female breast cancer. But obviously, we want to open that to male breast cancer. So for that, we probably need to produce a functional taxonomy to clarify which males had a particular dependence on the androgen receptor for the disease biology, so we can design clinical trials in the optimal way to have positive results if possible. And for that, we count on Valerie on their knowledge on this androgen receptor. Okay. And this is a way of, so this is the A is the main core idea that we want to test in our project, and the B will be androgen receptor and the biology around androgen receptor, probably a functional taxonomy androgen receptor, and the C will be, as said, host-specific immunity. But we think, because we think that immunity is one of the most relevant avenues for research in male breast cancer for the reasons I've already mentioned. Okay, so we put together all these experts. We are writing this grant or this project, and we will keep looking for funding in order to produce all these all this evidence on our series in GCAM using previously produced evidence. And I'm finishing now. What lessons have we learned? Well, I'll first tell you that we've learned in doing research in male breast cancer. This is an unstoppable area of research. And this is quite good news. This is an unstoppable area of research. More and more researchers are getting interested in male breast cancer because, for the reasons I've already mentioned, it's a nice way in order to elaborate new hypotheses on breast cancer in general. That's first. Second, that we've got fuel for doing that, and this fuel is the interest of patient associations. You know, in Spain we've got a very energetic interaction with INVI, which I probably know. You probably know that Marius is not Marius is not in his best situation right now, but he's been extremely energetic in order to fuel all this collaboration, and we are so grateful to him, and to INVI. So patients have been absolutely a must for the development of this program. The other thing that we learned is there is international collaboration or there is not research to be produced, because this is sufficiently rare as a disease to avoid any other way of doing that. Either there is international collaboration or there is no research. And probably the other way of doing that is that, of lessons we've learned, is that we need to develop research in another way. What have we changed so far in the therapeutic approach to male breast cancer? Was probably very little, as almost mentioned so far. So there is a need to make decisions and to explore other ways of doing research. And to do that, that's why we have set up this international consortium. And I want to highlight a paper that appeared recently, a couple of years ago, in a clinical pharmacological therapeutics that it was a heads up for me, because there was real world data from more than 1,000 men with male breast cancer. And there was, I mean, irrespectively of the particular area of research, that was the utility of palbociclib, which is a CDK inhibitor in advanced disease for male breast cancer. I mean, what basically thrilled me were not the results, but the fact that somebody has been able to put together evidence on more than 1,000 male breast cancer patients, and that's something remarkable. So when this appears, that listen, there must be another way of doing research when you are able to do this. And I mean, putting patients into a clinical trial, you've been in the presentation by Professor Leone, you've seen how difficult it is, how hard it is to recruit into clinical trials. But we are able to put together data from over 1,000 treated in clinical practice. Well, then we need to use that. And we need to discuss that with the medicine agency, with the FDA, with the EMA, so we can open new avenues of doing things in this rare disease setting. So that is the other thing that has opened us the eyes in terms of the way we conduct research. And this is my last slide, I think. So what we've done so far is that we have, we are producing these material results of the registry. We're developing the translation RDERN program. We have set up this first set of the international consortium, but we are really interested in exploring the possibility of putting this registry generation ability in real time, not only from a retrospective fashion, but in real time, producing continuous data from clinical care of these patients in a continuous way. That will be really interesting. We don't have the funding for doing that, but we are looking for. And as mentioned, we need to open new models of clinical trials, because otherwise we will be changing so little in the care of our patients. That's something that we cannot afford. So, and that I think is my last research. Yeah, my last slide. I'll stop here, and I'm open for your questions if there's any.